Good day, everyone. So, today we will discuss one of the fluid and electrolyte disorders, which is the hyponatremia. So, first, let's briefly discuss the pathophysiology of hyponatremia. So, hyponatremia, in some contexts, it is present when serum sodium is less than 135 millimoles per liter. Hyponatremia is characterized by changes in serum osmolality or the plasma osmolality, which is defined as a measure of the different solutes in plasma. So we can classify hyponatremia according to serum osmolality, which can be isotonic hyponatremia, hypotonic hyponatremia, and hypertonic hyponatremia. In hypotonic hyponatremia, it can be also classified according to volume status, which can be hypovolemic, euvolemic, and hypervolemic. So let's first focus on the three classifications of hyponatremia according to the level of serum osmolality. So here, mapapansin nyo na meron tayong isotonic hyponatremia and hypertonic hyponatremia. So originally, hyponatremia meaning meron siyang low serum osmolality. Ang kanyang serum osmolality is lower than the normal range. So, hypotonic hyponatremia is called the true hyponatremia. So, bakit dito meron tayong isotonic hyponatremia and hypertonic hyponatremia, which is normal and high level of serum osmolality. So, in some patient laboratory tests or lab artifacts, we can identify isotonic hyponatremia and hypertonic hyponatremia. And for the hypertonic hyponatremia, in this case, increased serum osmolality causes an osmotic shift of water from interstitial and intracellular space to intravascular space, leading to a relative increased water to sodium. The situation may be seen in severe hyperglycemia or with the use of an osmotically active substance such as mannitol and radiocontrast agent. So, sa isotonic hyponatremia naman, here, the aqueous fraction of the serum sample is reduced because of the volume occupied by the macromolecules. So, as I've said, this can be due to lab artifacts, and this artifact is seen only through the use of certain type of assays. And since there is no actual change in water or sodium status, this type of hyponatremia can be also called as pseudohyponatremia because the serum osmolality here is normal or isotonic. And artifactual causes of hyponatremia in isotonic state includes fever, hyperlipidemia, or hypoproteinemia. So let's go back to the hypotonic hyponatremia, which is the true hyponatremia. So in hypotonic hyponatremia, we should assess the volume status of the patient. And with that, we can identify it as three subtypes of hypotonic hyponatremia, which is the hypovolemic, euvolemic, and hypervolemic. So, mag-focus muna tayo dito sa hypovolemic first. In hypovolemic, if the patient is hypovolemic, there is a depletion of sodium and water, but the sodium deficit exceeds the water deficit, causing hypovolemia and hyponatremia. So, in hypovolemic, the urinary sodium level is less than 10 milliequivalents per liter. Hence, extrarenal salt loss is also present. And this is seen in situations with fluid losses such as gel losses due to vomiting, diarrhea, or dehydration. Another case of hypovolemic hyponatremia is when urinary sodium is greater than 20 milliequivalents per liter, and hence renal salt loss is present. So this may be due to the use of diuretic ACE inhibitors, nephropathies, mineralocorticoid deficiency, and cerebral sodium missing syndrome. Now, punta naman tayo sa hypervolemic hyponatremia. So, in this case, if the patient is said to be hypervolemic, it means it is in volume overload. So, in this case, excessive water retention has occurred due to sodium retention and there is volume expansion. So, it is seen in edematous state as well in conditions leading to fluid overload, including congestive heart failure, liver disease, nephrotic syndrome, and advanced kidney disease. And lastly, euvolemic. The patient is said to be euvolemic when there are no major disturbances of body sodium content. Hence, the patient is clinically euvolemic. So, take note that sodium itself is in normal quantity in euvolemic state, but for some reason, there is excess water. And excess body water may be the result of abnormally high intake, either orally or as a result of medically infused fluid. And with this, they are seen with patients with SIAD or syndrome of inappropriate antidiuretic hormone with post-operative hyponatremia, as well as hypothyroidism, psychogenic polydipsia, or this is the excessive drinking of water, which is often seen in patients with psychiatric or neurodevelopmental disorders. Also, beer potomania, ito yung excessive drinking of beer and idiosyncratic drug reaction with the use of thyroid diuretics and ACE inhibitors, injurious exercise, and can also be seen with patients with adrenocorticotropin deficiency. So, hypotonic hyponatremia is classified according to volume status and it can be hypovolemic, euvolemic, and hypervolemic. Hence, hypotonic hyponatremia is also called as true hyponatremia. Base dun sa tatlo na isotonic hyponatremia, hypotonic hyponatremia, and hypertonic hyponatremia. So, let's move on to the major causes of hyponatremia. So, major causes of hyponatremia may be due to, first, EIVF depletion or extracellular and intracellular volume and fluid depletion. This may indicate true volume depletion and it indicates congestive heart failure or cirrhosis. Of course, another major cause of hyponatremia is SIAD or syndrome of inappropriate antidiuretic hormone. Another major cause of hyponatremia is hormone mediated, which can be due to adrenal insufficiency, hypothyroidism, and pregnancy. Also, disorders in which ADH levels may be appropriately suppressed, or disorders in which antidiuretic hormone levels may be appropriately suppressed, and this may indicate advanced renal failure, primary polydipsia, and beer drinkers potomania. Gaya na sabi ko kanina, primary polydipsia or yung psychogenic polydipsia, ito yung excessive drinking of water sa mga patients with psychological disorders. The beer drinkers potomania naman is excessive drinking ng beer. And lastly, another major cause of hyponatremia is pseudohyponatremia, which can be high plasma osmolality induced by hyperglycemia, mannitol, and urea. And it can also be induced by normal plasma osmolality induced by hyperlipidemia, hyperproteinemia, glycine infusion, and glycine infusion. So, what are the signs and symptoms of hyponatremia naman? So here we have the mnemonic salt loss. So N stands for stupor or coma. A stands for anorexia or the lack or loss of appetite for food and can be induced by vomiting and nausea in hyponatremia. And L stands for lethargy or yung panghihina And T stands for tendon reflexes, which is mababa yung tendon reflexes nila. And L stands for limb muscles, which is their muscles are floppy and parang di nila mabend yung knees or arms nila. That might be a symptom and sign of hyponatremia. And O stands for orthostatic hypotension. Ito yung nahihilo ka or nandidilim kapag tumatayo ka or humihiga. And S stands for seizures and S stands for stomach cramping. So, take note din na kapag naka-experience ka ng 4 or more among these pneumonic na salt loss, 4 or more signs and symptoms, ibig sabihin, meron ka ng hyponatremia. So, let's move forward naman sa complications of hyponatremia. So, in this picture, we can see the brain adaptation process during hyponatremia, which may be associated with the rare but serious consequences of osmotic demyelination syndrome or ODS if the rate of correction of sodium is too rapid. ODS can develop 1 to several days after aggressive treatment of hyponatremia, even with water restriction alone. So in this picture, we can see the process, what will happen to the brain if there is an improper and proper therapy of hypotonic hyponatremia. Also, ang focus natin dito is hypotonic hyponatremia because, like what I've said earlier, originally hyponatremia is characterized by low serum osmolality. Hence, it is acute hyponatremia. So, yun ang focus natin dito. And in the picture, we can see here the normal picture of the brain with normal osmolality. So, with the immediate effect of hypotonic state, hypotonic hyponatremia results in water entering the brain. So, makikita nyo dito na yung brain is parang siyang nag-swell nang nakaroon siya ng water gain. And through rapid adaptation, water gain leads to cerebral edema, intracranial hypertension, and a risk of brain injury. It also indicates loss of sodium, potassium, and fluoride. And within hours, however, solutes exit the brain tissues, inducing loss of water. So, sa rapid adaptation, merong loss of sodium, potassium, and fluoride, including loss of water as well. So, through slow adaptation din naman, nagkakaroon pa rin ng loss of organic osmolyte and loss of water. So, this loss of water will lead to swelling of the brain. Napansin nyo din, nung nawala na yung water sa brain, is nawala yung swelling niya. So, this adaptation process helps explain why even patients with severe hyponatremia may have few symptoms if the condition develops slowly. So, kahit na nag-rapid adaptation ka and slow adaptation, if nagbigay ka ng improper therapy or rapid correction of the hypotonic state, it can lead to osmotic demyelination. So this rapid correction of this hypotonic state can lead to the shrinkage of the brain. And shrinkage of the brain leads to demyelination of pontine and extrapontine neurons, which can cause neurologic dysfunction in the form of quadriplegia, pseudobulbar palsy, seizures, coma, or even death. So, napansin nyo naman na from normal brain, yung brain, nag-shrink siya. And that's the result of the improper therapy. So, kapag nagbigay ka naman ng proper therapy, which should be a slow correction of the hypotonic state, the brain will return back to its normal state. So, always remember na kailangan i-analyze muna natin mabuti bago tayo magbigay ng treatment sa hyponatremia because it can lead to serious and life-threatening effects. So, and take note also that patients with potassium depletion and malnutrition are at increased risk of this complication. So, that's the complications of hyponatremia.
So now, good day everyone. I will going to discuss the actual case of the patients who had the hyponatremia. So here is the case. A 27-year-old man having a weight of 95 kg had been drinking alcohol and energy drink for 6 hours at a party. So, meron tayo dito old man na umaten ng party for 6 hours at uminom ng alcohol and energy drink that contains 25 ml to 100 ml of caffeine and taurine, vitamins, sugar, citric acid, and caramel. So, the morning after the party, he noticed that his entire face, neck, and extremities were swollen. So, kinaumagahan, dito niya na napansin na namamagana yung mukha niya, leeg niya, at yung mga kamay at paa. And afterwards, he experienced nausea, repeated vomiting, diarrhea, and dark-colored urine, along with excessive weakness and fatigue, which continued to progress. So, after nun, doon na din na-experience niya ng magsuka din at magtae. And also, yun nga, excessive weakness and fatigue. So, 2 days after the party, conscious and oriented, the patient contacted his doctor and was hospitalized at a general hospital. So after 2 days, tinawagan niya ng doktor niya at nagpa-admit na siya sa hospital. And laboratory tests performed upon admissions showed he had the leukocytosis with a predominance of granulocytes, increased levels of urea and creatinine, and the presence of hypokalemia. So, upon admissions, ni-laboratory test siya. At based sa laboratory test niya, dito nakita na meron siyang leukocytosis with a predominance of granulocytes. Also, mataas din yung levels of urea and creatinine. And dito din nalaman or nakitaan na meron siyang presence of hypokalemia. His biochemical urine test showed microscopic hematuria and positive proteins. An analysis of arterial blood showed hyponatremia with sodium level below 100 millimole per liter. So dito, basta sa biochemical urine niya, dito na din nalaman na meron siyang hyponatremia base sa sodium level niya na masyadong mababa, which is 100 millimole per liter lang. And also, the patient then developed an acute systematic seizure and coma. So, dito nagka-seizure na din siya. Nag-seizure na siya and may coma na. At doon na siya dinala sa emergency center. Then, upon admission sa emergency center, the patient was comatose na, which is Glasgow Coma Score 3. And based on my research, that Glasgow Coma Score 3 is the worst and Glasgow Coma Score 15 is the best. And the hypertensive of 140/70 with a respiratory rate of 30 breaths per minute and a heart rate of 90 beats per minute. And a throat subculture test was done as well at the hospital, which revealed Streptococcus beta hemolyticus of group A and negative anti-streptolysin O titer. So, yung repeated throat swab niya was negative and a seroconversions of previously negative anti-streptolysin O titer was seen together with a decrease in C3 complements components level in which the diagnosis of acute post-streptococcal glomerulonephritis was established. So dito nakitaan na din siya or na-diagnose na din siya as merong acute post-streptococcal glomerulonephritis. And there were no signs of hyperbulimia at the time of admissions. Wala namang nakita sa kanya based sa mga test na may hyperbulimia siya. And hence, therapy with hypertonic sodium, fluid restrictions, corrections of potassium, and antibiotic was introduced. So it includes nga the fluid restrictions, and his antibiotic was penicillin at 1.6 million units every 12 hours, along with proton pump inhibitor and metoclopramide. So, sodium level in bloods were gradually normalized by not more than 0.5 millimole per liter per hour. So, dito, nag-normal na yung sodium level niya. And also to avoid central pontine myelinolysis, and the patient gradually regained consciousness over the following 3 days. So, after 3 days, bumalik na yung conscious niya. His hypertension was treated with angiotensin-converting enzyme inhibitors given on several occasions. So initially, high levels of urea and creatinine also normalized, and the patient entered the recovery phase with diuresis of 4,500 ml per day. But proteinuria with microscopic hematuria remain. So dito, yung mataas niyang level ng urea and creatinine, nag-normal na, naging okay na, and the patient also entered the recovery phase na, and with diuresis of 5,400 ml per day. Pero dito, sinasabi na meron pa din siyang presence of proteinuria with microscopic hematuria. And after 14 days naman, the patient was discharged from the hospital and advised to take care of his hygiene and diet and to abstain from alcohol and energy drink. So after 14 days, okay na yung patient, dinischarge na siya, at inadvisean na lang siyang alagaan yung hygiene at diet niya, and also iwasan yung alcohol and energy drinks. So 1 month later, laboratory findings still indicated the presence of proteinuria. So after 1 month, bumalik siya, nagpa-laboratory, and based sa laboratory findings niya, nakitaan pa rin siya ng presence of proteinuria. So we have here the subjective informations. So we have the morning after the party, he noticed that his entire face, neck, and extremities were swollen. Also experienced nausea, repeated vomiting, diarrhea, and dark-colored urine, along with excessive weakness and fatigue, which continued to progress. Also, he developed an acute systematic seizure and coma, and diagnosed with acute post-streptococcal glomerulonephritis. So here is the subjective informations na galing sa patient natin or sa case ng patient natin. And now let's go proceed naman sa objective informations, which contains patient informations, lab tests, or physical exam and medications. So now, we focus tayo sa patient informations. So, male patient, 27-year-old man with severe acute hyponatremia and the presence of proteinuria. Also, 95 kilogram body weight and hypertensive, which is 140/70, with a respiratory rate of 30 breaths per minute and the heart rate of 90 beats per minute. So, based on his lab test or physical exam, analysis of arterial blood shows hyponatremia with a sodium level below 100 millimole per liter. Blood urea nitrogen is 14.5. Creatinine is 286 micromole per liter. Potassium is 2.8. pH 7.37 in urinalysis test, and proteins and RBC in urine is positive. So, based on his medication naman, hypertonic sodium, fluid restrictions, and penicillin at 1.6 million units every 12 hours, along with proton pump inhibitor and metoclopramide, and diuresis of 4,500 ml per day. So now we're going to proceed to the assessment based on the information gathered. We have here the problem list. We have here 5 problem lists. First is hyponatremia, acute post-streptococcal glomerulonephritis, abnormal laboratory test that it shows that it has the presence of leukocytosis with a predominance of granulocytes, increased levels of urea and creatinine, presence of hypokalemia and proteinuria, and the patient also developed acute systematic seizure and coma. So now let's proceed to his lab test or physical exam. Based on what I have said earlier, na meron siyang presence of hyponatremia dahil sa baba ng sodium level niya, which is 100 millimole per liter. And according to Mayo Clinic, the normal blood sodium level is between 135 and 145 milliequivalents per liter. So hyponatremia occurs when the sodium in your blood falls below 135 milliequivalent per liter. So dito, masyadong mababa yung kanyang sodium level kaya nagkaroon siya ng hyponatremia. And based on his creatinine naman, that according to Mayo Clinic, the typical range for serum creatinine is pag adult or for adult men is 65.4 to 119.3 micromoles. And based sa case ng patient natin is meron siyang 286, so masyadong mataas. Na doble yung normal range lang dapat. So, ito masyadong mataas yung creatinine niya. And his band naman or blood urea nitrogen is 14.5. That according to Mayo Clinic, the millimoles per liter internationally or in general, 2.1 to 8.5 millimole per liter is considered normal. So dito, ang normal is 8.5 pero ang meron sa patient natin is 14.5. So masyadong mataas yung kanyang band. And sa potassium level naman niya, that according to National Kidney Foundations, the normal and high potassium level measured in millimole per liter are as follows. Kapag normal, between 3.5 and 5, high from 5.1 to 6, and dangerously high over 6. So, if potassium levels are low or below 3.4, it's called hypokalemia. So, based on what I have said earlier, that he has the presence of hypokalemia dahil mababa yung potassium level niya, which is 2.8 lang. And according also to the National Kidney Foundation, that potassium levels lower than 2.5 can be life-threatening. So, sa awa ng Diyos, hindi naman na umabot sa 2.5 yung potassium level niya. So, yun, 2.8, that below 3.4 is hypokalemia, and he had the 2.8 millimoles per liter potassium level. And here is subjective information. According to Mayo Clinic, that the symptoms and signs of hyponatremia may include nausea and vomiting, headache, confusions, loss of energy, drowsiness and fatigue, restlessness and irritability, muscle weakness, spasms or cramps, seizures, and coma. So, based naman sa case natin, sa case ng patient natin, he experienced nausea, fatigue, seizure and coma, etc. And based on according also to Mayo Clinic, the PSGN or post-streptococcal glomerulonephritis is a kidney disease that can develop after infections caused by bacteria called Group A Streptococcus, na nasabi ko kanina na develop din siya sa Streptococcus group A bacteria. Kaya rin siya nagkaroon ng post-streptococcal glomerulonephritis. And here in our assessment, we have the problem list, and the drug therapy problems that we needs additional drug therapy based sa case niya kasi is hindi pa din gumagaling ang kanyang proteinuria. So need natin mag-additional ng drug therapy. And here our plan. And in order to manage the patient's proteinuria, the treatment may include, so we suggest to take low doses of ACE inhibitor or angiotensin converting enzyme inhibitor like ramipril orally 1.25 milligram once a day in 1 week. So according to Medscape, that ACE inhibitor have renoprotective properties which may be partially due to the other dynamic and non-hemodynamic effect of this drug. So dito, and also according to PubMed, that we can administer the ramipril orally 1.25 once a day in 1 week, the patients who had the high proteinuria. It is to lower his proteinuria, then after the treatment, kailangan din natin i-monitor yung sodium level niya para ma-avoid yung recurrence ng hyponatremia. And also we suggest to monitor his blood pressures level as well after the treatment if his ACE inhibitor treatment will have a significant effect in managing his hypertension. And also, we need to watch out for the serious and adverse effect of ACE inhibitor like dry, sickly, and often bothersome cough. Also, the most significant adverse effect of ACE is angioedema. So, it can affect any part of the body, including the intestine, but the most concerning is edema of the tongue, glottis, and or larynx, causing airway obstruction. And in order naman to manage the patient's hypokalemia, the treatment plan may include, so upon searching, we found out that the ACE inhibitor can cause the body to retain more potassium than usual. So we suggest to continue the treatment of ramipril orally, 1.25 milligram once a day in 1 week, and monitor for elevations of the patient's potassium level until it reaches normal. So the drug events or adverse events of this was the ACE inhibitor can cause the body to retain more potassium than usual. So this could raise your blood levels of potassium too high, a condition called hyperkalemia. So pag masyadong tumaas yung potassium natin, is pwede tayong magkaroon ng hyperkalemia. So need natin i-monitor yung elevations of the patient potassium level until it reaches normal. And in order to manage the patient's hyponatremia, the treatment plan may include, so if hyponatremia persists again, if we will have severely symptomatic hyponatremia, we suggest to administer 3% sodium chloride, which was 100 ml intravenous or IV bolus, and repeat it up to twice if symptoms persist. And for mild to moderate symptomatic hyponatremia, we suggest administering 3% sodium chloride or slow infusions. Use sodium deficit formula to calculate the rate of infusions, but recalculate rate with frequent sodium monitoring. And upon administering, we should also watch out for the adverse event of normal saline, which may occur secondary to solutions or technique of administrations. So these effects include febrile response, infections at the sites of injections, venous thrombosis or phlebitis extending from the site of injections, extravasations, and hypervolemia. And we have here the lifestyle change or non-drug therapy for hypokalemia. A low sodium and high potassium diet is appropriate. Also, avoidance of specific food like licorice may also be necessary for high-risk individuals. And lifestyle change for or non-drug therapy for hyponatremia naman, the initial correction rate with hypertonic saline should not exceed 1 to 2 millimole per liter per hour, and normal hyponatremia should be avoided in the first 48 hours. And review the lifestyle change non-drug therapy for proteinuria. We need to maintain blood sugar, blood pressure level, and a healthy weight. Exercising regularly at least for 30 minutes in a day. Eating food low in calories, sodium, phosphorus, and potassium. Avoiding intake of supplement rich in protein. Being hydrated by drinking an adequate amount of water, and by avoiding protein-rich foods such as cheese, butter, beans, and meat. So that's the end of their discussion. I hope you learned something, and good day, everyone.